Sure. Thanks for the opportunity to talk with you all, and it's already been a very interesting meeting. I actually come from originally a background of working on tuberculosis in the former Soviet Union. I'm a medical anthropologist by training, as well as now a cardiologist. And Bridget was sort of asking us about how we ended up where we are in terms of now identifying as a non-communicable disease person. And I think that clearly there's some aspect of sort of professional differentiation, right, that we all sort of fall into. And part of mine was just in our organization at Partners in Health, et cetera, there were a lot of people working on drug-resistant TB, and I was nowhere near as smart as them. And I wanted to work in an area where there had been less work in medical anthropology, et cetera. And I was interested in ideology and was hungry sort of for finding new stories and ones that like the ones in TB that had excited me. So I think that coming from that TB world and now kind of working broadly on non-communicable diseases and injuries in populations living in extreme poverty, I think that my major reflection about why we're kind of in two different spaces has to do with some of the discussion we had yesterday about simplicity and in public health, the way that we search for simplicity. And I think that what has happened historically is that if we look at the conversation about health priorities in the world's poorest populations, the way that we found simplicity is that we've identified a number of major largely infectious threats that are the major killers of children and young adults. And there's a very strong equity imperative, there's operational clarity about those things, and it's been a very important observation. At the same time, there's been a sense that the other stuff is just kind of too complicated in a way, or that at a global level, especially, we're in the I think as one person I talked to at UNICEF said, we're in the wholesale business. We can't get into these things that are not in the top 5 or 6 causes. So partly I think as a result of that, the way that the NCD space has evolved is kind of the inverse of that, where historically there's been a lot of simplicity and clarity, operational clarity, more so from the risk factor standpoint in high-income countries. And so we sort of had a separate conversation that felt very comfortable about older populations, the nature of their epidemiology, and what are the top 3 or 4 things. And really it's largely about, to be honest, ischemic heart disease, right, and stroke. And the risk factors associated with that. And so we've had these 2 different spaces that are defined by their own simplicities. And what that leaves out is the complexity in between. And if you think about both of those spaces, infectious disease and non-communicable disease, the major conditions on the infectious disease side, of course, leave out certain things. Some of them were captured in terms of neglected tropical diseases because they sort of shared a common intervention, mass antibiotic, or mass not necessarily antibiotic, but mass chemo administration of some kind. And then, but of course, there's still issues that aren't addressed, and there's also the complexity within the major infectious diseases, such as drug-resistant tuberculosis. On the non-infectious disease side, it's kind of all complexity if you really look at it, right? Because there's, within the cardiovascular diseases, there's obviously much more than just than ischemic heart disease and stroke, rheumatic heart disease, cardiomyopathies, congenital heart disease. Within the cancers, of course, there's enormous complexity. And then there's, all of the disease categories that constitute NCDs, from, all the congenital conditions, congenital hydrocephalus, gastroschisis, to name a few, all the musculoskeletal conditions, neurological conditions, basically most of the ICD, if you're frank about it. And so I think that what we're seeing maybe in terms of convergence, or one kind of convergence, is this convergence towards having to have new ways of dealing with complexity or simplifying that complexity. When our old models of achieving simplicity through single diseases or single risk factors is kind of exhausting itself, because of course, there are shared risk factors, but a lot of these things it's hard to say exactly in what meaningful way there's a shared risk factor between congenital hydrocephalus and ischemic heart disease or whatnot. And so that's, I think later we'll have a chance to talk a little bit more about this, but I think what we really need is a kind of new science of integration, particularly in global health delivery, that helps us wade through this thicket that we're in within the convergence. I don't know if I'm running up on my time, but I have a minute. I think Bridget asked a couple sort of concrete lessons, from one field to the other. I would say the one thing that I would remind ourselves about is that I think that in the infectious disease world, broadly generalizing, one advantage of it, I think, that's been quite strong is that there's a lot of equity there in the sense of priority to the worst off, that in some ways is sort of incidentally related to the diseases. But if we think about what we mean by priority to the worse off, we mean priority to those who are materially worse off, the poor, those who are worst off, maybe in terms of lifetime health, i.e., children, young adults. And that equity imperative has really given the infectious disease movements of our time some clarity, some strength. It's also been maybe part of the reason why, in some ways, tuberculosis or some of the diseases have maybe less of that than child health. They've struggled. And I think that on the non-communicable disease side, we shouldn't lose that. There's an enormous heterogeneity within NCDs, as much or more so as within the infectious diseases. And some of them are childhood diseases, some of them are highly lethal, some of them less so. Some of them are just less disabling, some of them kill people later in life. And we shouldn't lose sight of those distinctions, and we shouldn't lose sight of the focus on equity that sort of came naturally to us in the infectious disease world.